All right, thank you for joining us today on today's event, where we're going to talk about cervical fusion with disc removal, and we're going to actually go through some documentation examples. My name's Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. I'm also joined by Jennifer, who is also a registered nurse on the Provider Outreach and Education team, as well as representative from Medical Review that will be helping with the question and answer portion of today's call. Few housekeeping items before we get started. So I mentioned this briefly before we started the webinar, but we have a link on our training center page at the top of the page at wpsgha.com, where you can get the education material for today's event. Jennifer also placed a copy of that in our live event page. Also on our live events page, or our training topic center, you're going to find all different things like training materials, upcoming events. You're going to find links to our actual encore presentations that you can watch from our YouTube page without actually having to go to YouTube. Those encores are recordings of our live events, and they're usually available on that encore page for 60 to 90 days, but they're always available on our YouTube page until the information is either outdated or new information, a new recording is done. If during today's event you have any questions, I want you to please place those questions in the chat. My assistants are going to be helping with those questions, and if we have time, we'll answer those questions live as well. If you're listening to this as an encore or as a live event, you're going to have the opportunity to take a survey or provide feedback on today's event. We value your feedback, and we want to know how this educational event helped you, if it helped you, and what you would like to see in the future. So if you're listening live today, Jennifer put a link in the chat to take our live event our live event survey and provide feedback. And you can take that at any time, but if you find you have to leave the event early, I do encourage you to use that link and to go out. Otherwise, you'll be redirected at the end, and I'll give you information on that. If you're listening via Encore, so the live event has already passed, you will have the opportunity to take the survey for the Encore. There's going to be a little eye with a circle around it. It's going to be in the top right corner. And there's also going to be a link to the description and a link at the end of the video. So moving on. On your slide right now is just a CPT copyright notice. I have to give this notice because we have CPT codes that I will be referring to in this event. So I do encourage you to go back and read this disclaimer. And now on the screen is a copy of our disclaimer. And basically our disclaimer says, I prepared this information today as a tool to assist you, our Medicare providers, in the Medicare laws, rules, and regulations regarding the cervical discectomies and cervical fusions. And the answers I'm going to give today are based on the laws, rules, and regulations as they stand today. However, Medicare is a somewhat often changing entity. And if the rules change tomorrow, it is your responsibility as a provider to make sure you are following the most current laws, rules, and regulations as they are in place on the data service that you provide them. We also ask that you not audio or video record this event. We're doing that for you. We're going to post it on YouTube so you don't have anything to worry about. Acronyms, Medicare's full acronyms. If you've been around long enough, you know it's like acronym soup, and there's an acronym for just about everything. On your screen are acronyms I may say or refer to in today's event. So if I happen to say something and you don't know what it is, just refer back to this page. Or if you see something in the event or I say something and it's not on this page, just put it in the chat if you don't know what it is, and either Jennifer or Candy will help you identify what that is. You know, we get so used to just spewing those things out that it's almost second nature sometimes. All right. So my objective for today is that you learn about the cervical fusion and disc removal requirements because they're part of the hospital outpatient department prior authorization process. And I want to go through some tips to avoid documentation findings. So by listening to this event today, we're going to go through and review the coverage criteria and limitations. We're going to talk about a little bit about the prior authorization requirements and some of the tips for that. And then we're going to actually dive into some documentation examples and things that maybe cause a non-affirmation upon review. And we want to help you identify those things in your own documentation so you can get your prior authorization requests affirmed the first time. So let's start today by discussing some coverage indications and how these relate to the prior authorization request. Sorry. My computer goes a little crazy at times. All right, so this coverage indication criteria comes straight from our local coverage coverage determination, and that's LCD L39788. And Jennifer's going to place a copy of that link that'll take you directly to that LCD in the chat. Now, this LCD, which became effective 7/14 of 2024, is the one that's currently in place. And the link that Jennifer provided is going to take you straight to that MCD database on CMS's site where all of our policies are housed. I'm going to take you there as well in just a second, but before we proceed, before we jump into that LCD, let's discuss these basic coverage indications. So in this LCD, there's 3 basic covered indications for your cervical fusions and discectomies, and they are decompression of symptomatic cervical nerve root impingement, decompression of symptomatic cervical canal stenosis, and decompression or stabilization of the cervical spine. So let me go into the local coverage determination, and I'm going to go, I went straight to cms.gov. And so once I'm on cms.gov, and you'll notice I didn't go to WPS, I went straight to CMS because all of our LCDs are housed on CMS. You can get there either way, but I go straight to the source first because I think it's easiest. If you go under Medicare and you go under coverage and you go to Medicare coverage database, here's where you're going to be able to search for the local coverage determination. Now, I can do this in several ways. I can put in the LCD number if I know that number, and which I do. Accept on the licensing agreement, and it's going to pull up the cervical fusion LCD, and that's the one I gave you the number for, the 39788. How can you verify that this is the correct local coverage determination for WPS? You can click on this down arrow for the contractor indication and our information and make sure it's a WPS LCD, because you want to be following what we are telling you as your paying and processing contractor. So then we had just talked about the coverage indications for the cervical fusion and discectomy. So here again is the information that we're going to go through, and we're going to go through all of these different points here. We're going to talk about all of this stuff in detail, some of the limitations as well. But when in doubt, go back to your local coverage determination and find the exact information. And I'm going to scroll fast, so avert your eyes if you have seizure disorders or this makes you nauseous. But I'm going to scroll all the way to the bottom of the page, and here is where you're going to find the local coverage article, the A59664, which is the billing and coding companion article for cervical fusion. So the LCD itself doesn't give you information about the codes, but the article does. And again, verify that you're still within the WPS, because sometimes computers do crazy things. And here is where you're going to find modifier information, you're going to find documentation requirements, and then you're going to find all your coding requirements. So if your prior authorization request is for cervical fusion, make sure, we're going to go into, I just went back to WPSGHA.com, and I'm going to go to the Topic Center of Medical Review, and I am going to scroll down here to prior authorization, and I am going to go to cervical disc removal updates. And here is where you're going to find all of your information that we put out, that we want you to know that's important for getting your cervical fusion and discectomies approved on prior authorization the first time. If I go back, and there's more than one way to find things, because you can always do a search, you can navigate, etc. So if I go back to prior authorizations, and I am going to go to the overview, I can then also look at, I'm scrolling medium fast, the CPT codes that must require a prior authorization request under this HOPD process. So if you are planning on either of these CPT codes and you are doing your service in a hospital outpatient department of an OPPS hospital and you bill on a 13X type of bill and you are planning to do this, it does require you to request a prior authorization with us as your Medicare contractor. And that's pertinent to either of these two codes. So a little bit of navigation information, tucked right into the middle of our event here today. But I think it's very important for you to know this information. Okay, so as we've gone back to the slide deck, I'm going to move on and talk about these coverage indications a little bit more. So let's start with the first indication, which is the decompression of the symptomatic cervical nerve root impingement. So cervical fusion under this category may be necessary when the patient has symptomatic nerve root impingement, and all of the following are met. So if you go back into the local coverage determination, I really need you to pay attention to those and statements and or statements, because there's a lot of things in here you have to have all of them, and there are some things that it is you can have this or this. But all of these things need to be supported in your documentation. So if they're and statements or all of the following, things we're going to look for in your documentation. This happens to be the things that we're going to look for to support this. And this is all of the following. So persistent or recurrent moderate to severe arm pain. So 4 or more on the visual analog scale. So we're going to look for this arm pain. we're also going to look that pain has been present for a minimum of 12 weeks within that current episode of pain. We're going to look to your documentation that there is documented failure to respond to conservative management in the absence of some exceptional circumstances, which we'll discuss later. We're going to look for the nerve compression that negatively impacts the activities of daily living. And then any or all other potential sources of pain or neurologic deficits that have been excluded. So we're going to look to make sure that those types of pains or deficits were excluded or were looked into. So again, arm pain, 12 weeks, failed conservative treatment, how it negatively affects the ADLs, and if the pain is something else that you've identified and ruled all of that out. So this is an all statement. As we move on, this is a continuation for the nerve root impingement. So MRI or CT, and there needs to be evidence of central lateral recess or foraminal stenosis at the level corresponding to the clinical myotome signs and symptoms, including one of the following. So this MRI or CT, and we need to see one of the following are met, so that there is either cervical degenerative disc disease, there are tumors that could be primary or metastatic, there maybe is some post-infection radiographic findings, or spinal instabilities. And you can read a little bit more about that on this slide or in the LCD. For those of you who are not clinical, myotome is a group of muscles which innervate by a single spinal root. So myotome testing, it's really an essential part of the neurological exam when you're suspecting radiculopathy. So myotomes are much more complex than dermatomes. Since each skeletal muscle is innervated by nerves derived from one or more spinal cord levels. So myotomes are a part of somatic nerve system, and the somatic nerve system is part of the peripheral nervous system. So what types of things would we be looking for in myotome testing? Different areas of tests are going to lead you to different levels of the spine that may be affected. So we're looking to see that the myotome testing is matching the imaging results, it's matching the patient's clinical signs and symptoms. So for instance, if you checked shoulder abduction by asking the patient to raise both of their arms to their side, then simultaneously, as strong as you can, have the patient do that, lift it up as strong as they can, and then the examiner is going to provide resistance to this movement. The examiner would compare strengths of each arm. So in clinical findings in that specific test could indicate a C5 issue. So we're going to look to see that all of those things, clinical exam, the testing, the deficits from the testing, and the MRI results are all consistent. And then like for C6, that may include testing of elbow flexion and wrist extension for strengthening. Just like I said, keep in mind, we're gonna look at the imaging and we're gonna look to see if it corresponds with those clinical signs or symptoms. Moving on to decompression of symptomatic cervical canal stenosis. So indications for symptomatic cervical canal stenosis, as they're written on the screen and in your handouts, include persistent or recurrent moderate or severe arm pain. So again, 4+ on that VAS for a minimum of 12 weeks, and again, failed to respond to conservative management, or nerve root compression that negatively impacts ADLs, or spastic gait loss and manual dexterity problems with sphincter control. And all other potential sources basically have been ruled out. And there's another and. So again, pay attention to these ors and ands. So the and includes, again, imaging evidence of that central stenosis at the level corresponding with those clinical myotones. All right. So I said we're going to get to some of the exceptions as to, because there's always rules and then there's exceptions to the rules. And not just in Medicare laws, rules, and regulations, but in the way that we evaluate and treat our patients. So let's talk about some of those exceptions to conservative therapy requirements when it comes to decompression of the symptomatic central nerve root impingement. So tin contaminant, myelopathy or myeloradiculopathy, which is, compression of the spinal cord in the neck. Symptoms may include problems with fine motor skills, pain or stiffness in the neck, loss of balance, and even trouble walking. So some indications under that would include one of the following. So there's the cervical myelopathy class 3 or above, and then the progression of the neurological deficits during the trial of conservative treatment. So we're trying other conservative treatments, but things keep getting worse. So that's what you're going to need to prove in your documentation. In the isolated radiculopathy, things are one of the following of these. So presenting with progressive motor weakness, significant motor weakness that interferes with ADLs. Again, we need to see which ADLs is interfering. You need to give indication of how it's interfering. It looks like I dropped an E there. Should be severe radicular pain limiting ADLs. And we want to see that, you have done a visual analog of the pain scale, and it's greater than 7 out of 10. And then we have another and, associated imaging to help support that, and clinical radiological correlation. So make sure if we're looking under here, we have all of these ands included. And then another exception would be loss of bowel or bladder. So if they're already experiencing loss of bowel or bladder, that is uncharacteristic, that could be an exception to that conservative management. As we move on, decompression or stabilization of the cervical spine. So that's a third indicator. Cervical fusion is considered reasonable and necessary for the decompression of the symptomatic cervical canal stenosis when the following are met. So there's been traumatic injuries, there are spinal cord tumors, there's infection involving the spine, or deformities that include the cervical spine. So let's break these up a little as well. Traumatic injuries include like fractures, dislocation, fracture dislocation, traumatic ligamentitis, disruption of one or more of the following of those things are met. Again, this is not an all, one of the following are met, and it's not an all, it's one of the following. Again, so the fractures or dislocations, which are likely to result in spinal instability, fractures or dislocations, which are already associated with neurological deficits, and, instability of the spine. And then next we have those spinal tumors. So any spinal tumors involving the spine or spinal canal when one of the following are present. So again, here's one of the following. So malignant or benign tumors, which have caused instability or neurologic deficit. Again, read all the information about these. So just because it's present, If it's not causing this, you know, it may not fit into the category. Again, moving on, expected treatment of the tumor, whether by chemo or radiation or surgery, and it will likely cause some instability or neurologic deficit, or again, there's already instability that's present. Moving on, infections involving the spine. Next, under that decompression or stabilization of the cervical spine, it is the infection component involving the spine. So infection involving the spine from any of these, you know, osteomyelitis, epidural abscess, and then again, we need to go down through here, imaging or other studies demonstrate infection, and there is imaging evidence of that vertebral body destruction, or documentation that the spine debridement is going to cause some vertebral instability, or again, that instability is already present. So moving on with the deformities that include the cervical spine. So when one of the following are met, and I'm not going to read through all these because I want to get to the documentation component. But again, these are outlined just right as they are on this slide under the deformities if you go into our LCD. And again, moving on with deformities, and we have instability and laminectomies. And here's another and statement, and one of those additional things, substantial functioning. So what does this all mean before we jump into the actual documentation? Depending on, and I am moving back in everything we went through, depending on the reasoning behind what you are doing, and the covered indications, if it falls into one of these indications, you really need to go through all of this information and make sure you're hitting all those and or statements, and they are covered in your documentation. If we can't find them in your documentation, we cannot, in good faith, affirm that prior authorization request. If your documentation is inconsistent and you have testing, myotome testing, and it is the physician's interpretation says, you know, this patient has deficits, but all the myotome testing are showing that everything is normal, we can't in good faith say, yeah, go ahead and do this. We'll give you Medicare money to perform the surgery when the documentation doesn't support that. So at this time, I want to pull over some actual documentation examples. And I'm going to ask Jennifer just to verify that you are seeing the PDF file that says chart 1.
Yes, I am.
Okay, let's scroll down into some of the documentation. So this is the prior authorization request form. This request form was done in our portal. So here we have noted the type of request. This is a subsequent request, so this is a second or third request by this provider. They've given all of the information about facility, the Benny, the Medicare number for the beneficiary, who's requesting it. This is all protected information that I have to sanitize out, so I can't show you that. The important things are, when do we anticipate doing this? And that is going to be on 9/10 of 24. So this is an older one, older chart. And what do they anticipate doing? So here is the CPT codes. And in the comments, they just put previous requests and they provided the unique tracking number of the previous request. One thing we highly encourage you to do in your request letter that's going to benefit you as a provider, use these comment sections to tell us where you plan on doing the surgery. Give us the cervical levels in which you plan to do these. If there are modifiers that you anticipate billing, make sure you put those modifiers in here as well. It's going to help us find that information in your chart better because we know right from the start what we're going after. So please utilize the comment section, whether you're doing it in the portal or hard copy version. They both have an area that you can give those indications. So as we move on, what we know right now, this is a 70-year-old male. There's no indication of the level or the side on that request form. We know that the request was for the 22551 1 unit, which is a fusion of spine bones with removal of disc at upper spinal cord, anterior approach, complex initial, and the 22552 1 unit, fusion of spine bones and removal of disc in the upper spinal column before second vertebrae of the neck, anterior approach, each additional space. They're both going to be 1 unit of service. And again, a subsequent request. Anticipated date of service was 9/10. So let's look at the documentation and see what we can find to support the cervical information. So this first is MRI of the pelvis. Not concerned with that because we're looking for cervical information. So I'm scrolling down here to the cervical spine and the views. So we know we need MRI results, and that's one thing that we're going to look at. So this MRI is these images, I think, are from 5/1, yes, 2024. And we have an indication of cervical pain. So as I scroll down, there is, I'm just kind of going through, there's on 5/1 cervical pain or cervical spine 6 or more views. So that would be for the flat plates or x-rays. And then we've got a little bit of information, cervical spine, moderate disc base narrowing. Here's some of the findings at C5 or C6. No flexion or extension, no pathologic motion. It's most prominent, the encroachment at 5/6. We have some degenerative joint of the cervical spine, mainly C5, C6, and then we know we have some lumbar stuff based on the other MRI. So as we continue to scroll on, I'm just scrolling through some of this additional information that was sent in that we don't necessarily need. It's about the lumbar issues as well. All right, so MRI of cervical spine, and this one was from 5/8. So we know here is the clinical history that was given. We have myelopathy, which is acute cervical spine. We have upper motor neuron syndrome, pain in hips and legs, unable to walk for long periods of time. We have some history of prostate cancer. Okay, so the findings in the MRI go down here. Cervical lordosis, I'm not even going to say this word today because words are leaving my mouth, but we're going through and we're looking at all the cervical issues. We're making note of this, how spinal cord, you know, we have a mild mass and how that affects. We're going to look again, when they do the myotomes to make sure they're matching what we're seeing on the MRIs. So we can go through here and get, you know, a lot of information. We got multiple spondylitic changes of the C-spine caused by a mass, and that mass is affecting C5, 6, 6, 7, compression that extends bilaterally, some from C4 to 7, no intermedullary signal changes. So as I keep scrolling down, I'm going to go down several pages here, trying to keep time in mind too. All right, so this ironically was sent in with us. This was an email that went from the provider around the office that they sent in too. And this was part of why we didn't affirm their request on the prior submission. And the reasoning was the submitted documentation does not support that it was medically reasonable and necessary for treatment of persistent or recurrent moderate to severe arm pain that has been present for at least 12 weeks. So this tells you right here, we did not find any indication of arm pain. We did not find that it was present for at least 12 weeks. It does not support that the ABLs were negatively impacted by the cervical nerve compression. So the submitted documentation does not support the physical assessment findings of motor deficits or reflex abnormalities related to 6-7 nerve root impingement. So this had come in before, and we told them exactly the components that were missing. This email was, you know, sent through in their office, and they had said to one person, I think it's because the radiology report was only showing mild issues. And so they're going to have the radiologist relook at it and see if he needs to give other indications, which in turn, we had the indications in the prior C-spine MRI. We just didn't have all that other information about the arm pain, the length, that it was at least 12 weeks, the ADLs impacted, and the assessment findings and like the myotome testing. So here we move on and we have a new exam, and you know, this man, if you read this, has a lot of lower back pain and radiating and bilateral weakness and issues, but he was told that he should do testing of the neck beforehand. And so then we start getting into this area here. He does have pain in the back of the neck, and he also has lumbar pain, right buttock, right thigh, right calf, right row, so all these pain areas. And then if you start reading through this, pain quality, dull, aching, progressive, worsening, 8 out of 10, but we don't know where. We don't know if this is the neck pain. We don't know if this is the buttock pain, the thigh pain. So this doesn't give us any indications about the neck, if there's any radiating pain from the neck, you know, what these are all associated with. So that's why I circled this, be leery in your documentation and make sure you're specifying, you know, for each area, because this guy has lumbar and cervical that they're concerned with, but the documentation encompasses all of that. And so we don't know how it's affecting him and his cervical spine issues. We have length of conservative treatment of several years, but we don't really know how long. It just says several years. Now, again, we only need 12 weeks, but in here, we're also going to expect to see what kinds of conservative treatments. And we have information up here that he did some physical therapy in December to February, 23 to 24, muscle relaxers, chiropractors, massage, NSAIDs. So that's good information, and it's been going on for several years. But again, some neck pain with extension, we don't know the severity of that neck pain either. As we move on and we look at some of the examination and testing, and we start seeing that like cranial nerves all look good, the neck and back inspection, a lot of that is coming out normally. Not all of it, but he's got some deficits that they do note. Head and neck, so he's got some decreased flexion and extension. And then Sperling maneuvers are negative for right and left, which is one thing we look at with the cervical spine as well. We've got range of motion in the arms as being normal. We've got legs, some decrease. And then again, we get into some of the myotome testing, and we're up here with some of these motor testings, and those are all coming out normal. Some of the flexions, we do have some absent reflexes. Again, things we look at, some other things that are normal as well. Again, some normal findings in the sensory. And then we look again for these assessments, et cetera. So the big thing with this chart, and I can continue to go through it, but there's a lot of that, aren't needed for our overall review. The first thing we look at with this request is there's no levels noted on the request. So we had to go fishing in the documentation where they plan to do the ACDF, and that ended up being C5 through 7. And then we go looking for the nerve root impingement, nerve compression, and nerve root encroachment, and we got things listed like the Sperling's maneuver, which is, again, used to assess that nerve root compression in the cervical spine, and that was negative both right and left. And then we also have negative myotomes listed. Next, we're going to go looking into the symptomology of persistent or recurrent moderate severe arm pain. Remember when we went through this earlier, because this is just kind of a repeat, they don't tell us which pain is associated with what, or which description of pains. So we can't put that all together. So again, we don't know if the balance and gait disturbances are from the lumbar issue or from the cervical spine issue. So those are other things that are noted. We looked at alleviating factors in that HPI, so leaning on the grocery cart, or laying flat, legs flexed and elevated. So they did do some PT, muscle relaxants, et cetera. So those type of things, we did find. So for this specific claim, the submitted documentation does not support the cervical fusion as medically necessary for treatment of persistent or recurrent moderate to severe arm pain, and that has been going on for at least 12 weeks. So that submitted documentation doesn't support that there's ADLs that are negatively impacted by the nerve root compression. It does not support the physical assessment findings of motor deficits or reflex abnormalities that were related to specifically C6 and C7 nerve root impingement. Therefore, this request was again non-affirmed for lack of documentation to support that medical necessity. So I have other documentation that I could show you, but in the interest of time, I see we are right at call end time. So I do want to respect everyone's time on that, and if it would be beneficial for you, I will consider hosting another event where we just go through documentation. If you want to go ahead and take that, give that feedback in that feedback survey, and when that comes up for you, and that way you can tell us if just a day going through only documentation is going to be helpful to you. And I'm looking at the chat. And someone just said, I received an email stating that I missed the webinar. Will you please make sure that you can see I've logged on? Barbara, if you could send an email to us, Jennifer's going to throw the email address into the chat so you can send me your information and I will double check on that. You should be getting another one that says, thank you for attending. I'm not sure why sometimes that does that. Sometimes if you listen by phone and you're on the computer, you'll get one that says I've attended and then one that says you didn't attend. So I apologize for that. I don't know why computers do crazy things sometimes. All right. Again, in the interest of time, you're going to receive a email in a little bit if you were on via web that looks like this. It has a certificate of achievement in it, so don't junk this email without reading it. If you happen to need contact hours for CEUs, this is where you're going to find them. So again, don't delete that. If you are only listening via phone, if you email us at wps.gha.education@wpsic.com, I will send you a certificate of achievement, via email if you didn't get that after I verify that you attended. Follow-up questions. If you think of any questions following this event, go ahead and email those to us. Just put cervical fusion examples in the subject line. Send out your question. If it's pertinent to everyone, I will send out the answer to everyone that participated in today's event, or make a follow-up document to send out to everyone. If your claim is customer service related, like I've billed this CPT code and this CPT code, and you've gotten to the point where you're billing and it's not processing in the system, those types of questions need to go to customer service. So you need to call them so they can look up your specific issue. Please don't send us any claim-specific information. I would hate for you to send PHI or PII over an email and for both of us to get in trouble for that. That would be really bad. Plus, I don't have access to the system, so I can't look up that information. Again, feedback. We value your feedback. You're going to get a link to the survey when this event closes, and Jennifer has also, or will also, place again a copy of that survey into the chat information. And I really encourage you to do that and give me your feedback. How did you like this event? Is it helpful? And by all means, what else do you need in the future? What's going to help you get the answers that you need? What kinds of events would you like us to provide? And namely on this one, if you want me to just set up an event that's just all documentation and no other information, we can by all means do that. All right, so please take that survey, give that feedback. On behalf of myself and Jennifer and Medical Review, I want to thank you for your participation in today's event. I appreciate you sticking with me for these few extra minutes, but this concludes our webinar for today, and you may now disconnect.